Good afternoon, everybody, and welcome to this week's Power Hour. And our guests today are going to talk about how to treat allergies and asthma during COVID-19. My name is Christina Nattagdag. I'm here today together with Aerik Williams, and together we head up the KIPL, the KNF Institute for Physician Leadership. And we have also our colleague Franklin Walker, who is also the moderator, as always, for our Power Hours. Today, we will also, as always, invite you to engage with the guests and the conversation that we're having. And to do so, we would like you to unmute. So just keep yourselves on mute for now, but you're welcome to unmute and ask your questions. You're also welcome to put the question in the chat box, and we will get to that as the conversation permits the flow for that question to be raised. This is also, as always, being recorded, and you will be able to access the recording sometime next week, towards the end of next week, on the KIPL landing page as well. And finally, as a reminder, before I hand over to Franklin, as you know, the purpose with Power Hours is to really foster and promote conversation, collaboration, and above all, community. And we are so thankful to our guests today to take the time to be with us, and we are thankful to all of our participants in the audience who are listening in. With that, without any further ado, I'd like to hand it over to Franklin.
Thank you, Tina. Welcome, everybody. We've been off for a couple of weeks, so welcome back to the Power Hour. I hope everybody out there is doing well and staying safe as we have a surge of coronavirus in the state and other places. And I want to welcome our panelists who are all going to be talking to us, as Tina said, about asthma and allergies. So the first thing I'd like to do is I'd like to go to each one of our panelists and have them give us a little bit of background on themselves and their particular practice. So David Gregg, please, sir.
I'm a board-certified emergency physician working at a smaller community emergency department on the periphery of the Triangle. I do work for a larger group that is based in the Triangle, covering a number of the different emergency departments. So I've got my ear to the ground amongst our kind of communications to kind of hear what's going on. I think that's kind of, I work, a dozen shifts a month, taking care of everything that walks in the door.
Super. Dr. Williams.
Yes. I'm in Salisbury, North Carolina, which is, midway between Winston-Salem and Charlotte, originally from Ohio, which you can probably see from my shirt in the background there. I'm an Ohio guy at heart, but I'm down here in Salisbury, North Carolina, private practice, board certified allergist and immunologist, private practice at Allergy Partners. See a little bit of everything in my allergy clinic, and treat all different classes, socioeconomic, and so I see a little bit of everything.
Super. Dr. Gayam?
Hi, I'm a board-certified allergy asthma immunologist specialist, and I practice in Cary, North Carolina, and I'm a solo practitioner in a private practice.
Wonderful. So let's go around again, and I'll come back to you, Dr. Gayam. How has COVID affected your practice? And I don't necessarily mean with your patients. We're going to get into that. But in terms of your practice, you are a private practice physician. Operationally, how's it affected you? How's your revenues? How's your staff, et cetera?
The timing of being hit with this pandemic wasn't the greatest. It was busy of the allergy season. Shutting down for 2 weeks without seeing patients was very difficult. And everything was up in the air about what we were going to do financially and how we were going to keep going. It took a lot of time to restructure our clinic to provide a safe environment for patients, learning telehealth, implementing it into the program, and using a lot of the social media and emails, getting the information out to the patients. So it was a lot of stressful time for the month of April. And I think as the time went on in May, I think we kind of got into a good flow now.
Super. Dr. Williams, let's come to you, sir.
Yeah, sure. So, I did not have to shut down, but I still experienced many of the same stressors that were previously discussed. we certainly have had fewer patients coming into our clinic. Our revenue was down. If I gave you a percentage, I'd say about 60 to 70% during the first couple of months. It's back up to about 85, 90%. And so, we had, a stressful time. We had to lay off one staff member. So, sort of the economics of practice became very real, earlier this spring. I've never, I've always just sort of concentrated on seeing patients, and everything else just sort of works its way out. This was really the first time that I really had to sit down and consider, finances in our clinic. But with that being said, we've done several things to keep our clinics safe, which our patients appreciate. We're giving allergy injections in patients' cars. We are, and we do all the things that the CDC and the North Carolina groups tell us to do. Recommend that we do. So it's been a trying time, but I'll tell you, I think that we've been triumphant.
Super. Dr. Gregg, I want to come back to you again. You're an ED, and before you answer that question, I kind of want to back up a little bit, because we had a group of ED physicians on early on, and as we were talking a little bit before we came on today, the EDs were all staffed up, ready for this big surge that never materialized, and now we've moved to a point that things are really going up. So can you talk about a little bit maybe about how things were early on, and where they are now in your world?
We definitely saw that drop in patient visits. A lot of the lower acuity visits that we see, throughout the day, we're staying at home, and there's some positives to that as far as appropriate use of the emergency department. But it is something that we kind of count on with our staffing. We are across, I guess, of all the emergency departments that my company covers, there was a huge hit of patient volume, anywhere 40 to 60% early on. And there's definitely a trend where we are close to baseline for this time, in previous years. Our staffing, both at my facility and across the other facilities that my company covers, there were some significant staffing changes that had to be made, but they are rapidly kind of ramping back up, both from a physician level and from a advanced practice provider level, to kind of accommodate the patients that are coming in. Even with the lower volumes, we definitely are seeing the higher acuity, and I think that's a trend that's definitely been well documented nationally, where folks are either kind of saving it up until they've reached a more critical stage in whatever illness they're having, or plus there's what is happening with coronavirus itself. We're not yet the critical hotspot that New York or Seattle has been, or some of the other areas have become, but it's been interesting. We are still not at the same staffing level that we were this time last year. We have one physician at a time at our facility, so that has not changed. But our help with the PAs and nurse practitioners are still reduced compared to what we were used to. And we're not there yet, at our facility at least, in bringing back those hours that we used to have.
Super. Thank you. Okay, let's move a little bit more into the specifics of allergy and asthma. And I want to come back to Dr. Gayam and get your view on whether asthmatics are really at a higher risk of acquiring COVID-19, and talk a little bit about how you come to that answer.
Looking at a lot of the case series that were reported so far, asthma has not been identified as a predictor for severe asthma.
Okay. And so, Dr. Williams, in your practice, have you seen any more seriousness about asthma or some of the other allergies, maybe food allergies in your patients that have been affected at a higher rate due to COVID?
No. I mean, I have not. With that being said, I have an N of 2 COVID patients that I've diagnosed here in my clinic.
Mm-hmm.
But I think that instead of perhaps expounding on my experience, I would sort of echo Dr. Gayam's sentiment, in that, patients with asthma, patients with allergies don't seem to be high risk for acquiring COVID, for being hospitalized for COVID, or mortality for COVID. And that comes from some data. Early on, when New York was the epicenter, and had you asked me that question, I definitely would have said, certainly, these patients are, patients who have allergies and asthma are at high risk. But the New York Times published an article in April where it looked at some of the data from that first surge in New York, and asthma was not a predictor. Hypertension, hyperlipidemia, COPD, diabetes, stroke, those are predictors, but asthma is not a predictor. And there's some data that's come out more recently out of Northwestern that also demonstrates that asthma is not does not put patients at increased risk. If they have COVID, it does not put asthmatic patients at increased risk for being hospitalized or for mortality.
Interesting.
If I could add one other thing, that data set out of Northwestern also demonstrates that rhinosinusitis is not a predictor for hospitalization or mortality for COVID. So it seems that these disease sets that we see in allergy and asthma seem to be spared.
I was actually, I had some downtime last night at work and was reviewing the details of that study in the Journal of Allergy and Clinical Immunology.
Yeah.
They identified the other things that were greater. They did two different studies, or two different models. One based on pure just demographics to kind of account for any differences, and the other looking at comorbid conditions. And when they did both different models, exactly like you said, they did not see asthma as an independent predictor of morbidity or mortality, but it did reinforce the other things that we were already thinking as far as non-Hispanic African Americans and Hispanics being at greater risk, and then all of the other comorbid conditions, some of which you just covered, were reinforced as kind of worrisome predictors for not doing well with the infection.
Yeah. Am I allowed to expound on that, Mr.
Please do. Yeah, absolutely.
Yeah, I mean, I agree. And so, it's sort of counterintuitive, right? Because we think that we know that asthmatic patients have increased susceptibility to viral infections that affect the upper and lower respiratory tract. So why would that not necessarily be the same for COVID? And so I was surprised when that data came out. One of the things that I think is interesting that some of the allergist immunologists have commented on is that there's a receptor called ACE, so angiotensin converting enzyme. It's a receptor, and that's how the virus makes its way. That's the receptor that it uses to make its way into the cell. And it's just interesting that asthmatic patients, particularly if they have extrinsic, allergic asthma, they oftentimes have downregulation of that receptor. And it just, so it's interesting that asthmatic patients are less likely to be hospitalized or suffer mortality. And I wonder if there's some things that are unique to many asthmatics that is protective, such as downregulation of certain receptors.
Do you know when folks are more on the COPD spectrum, those are typically going to be your older patients that usually had a heavy smoking history? Do you know if there's that same downregulation? I mean, those folks are going to have your other comorbid conditions, your high blood pressure, your obesity, your heart disease that we know are problems with COVID-19 infections. Do you know if that downregulation is also seen in that population? Is it known?
I don't know. I don't follow the COPD data as closely as I follow the asthma data. But what I'll tell you, and this comes out of a study from Harvard where they looked at patients who are asthmatic and whether or not they're at increased risk to suffer severe morbidity from COVID. And what they found is that patients that have, the extrinsic allergic seasonal sort of asthma, oftentimes they are not at increased risk. And they are also the group that is more likely to have that that downregulation of that receptor. but that's not necessarily true for extrinsic asthma that is the non-allergy sort of asthma. And those patients are actually seen in the hospital more frequently from their COVID. And you just sort of wonder whether or not that protection, that I'm calling it protection, but the downregulation of that receptor in allergic asthma patients is protective. But for extrinsic asthma, maybe COPD, because if I remember correctly, COPD was a risk factor in that New York Times article. I wonder whether or not those patients have any sort of degree of protection.
Interesting. So, Dr. Williams, you mentioned something a while back before you guys got into the conversation, part of the conversation about the New York Times, which was fantastic, about how racial disparities are hit, harder in COVID. And I'm wondering how that's played out maybe in some of your patients. Have minorities been hit harder because of that? Have you seen that play out in your practice with asthma and allergies?
Yeah, sure. I mean, certainly, I have seen patients that are lower socioeconomic status, and they're minorities just like me. Our group is more likely to be socioeconomic status, and so yes, I mean that leads to worsening of asthma, but not just asthma. Some of the other risk factors that have been identified as risk factors for acquiring COVID and having significant morbidity and mortality from COVID. And we've known this. I mean, COVID has just sort of exacerbated this, but we've known this. We've known this, for years. Lower socioeconomic status, groups, minority groups that look like me. It's difficult to buy nutritious foods, and so therefore we develop hypertension, hyperlipidemia, obesity, etc., and that puts us at increased risk not only for those disease states but for COVID. Unequal access to providers, having to travel further distances to see primary care physicians, not being able to afford medications. All of that. I mean, we saw this before COVID, and I saw this in my practice before COVID, COVID's just exacerbated this. Whenever I get asked this question, I always refer to a young man in my clinic. He's probably 8, 9 years old, and his mom's single mom, and he has asthma. He's bad asthma, and he's got a mold sensitivity, cockroach sensitivity that really drives his asthma flares. And he was living in a mold infested, dilapidated sort of housing. And that just caused his disease state to get worse. And it's only until he was able to move before his symptoms got better. Allergy shots, medicine, none of it helped to get better. So that's a disparity. And we see that I see that in my practice.
Interesting. Dr. Gayam, same question. Are you seeing some of that play out in your practice?
I think in the area where I'm living at in Cary, I don't see much of that. I have a few patients that kind of followed me from my previous practice as an internist that I still see who come from Henderson, which, like Dr. Williams was saying, that they can't afford the medications. They have a lot of multiple risk factors that puts them at a higher risk for getting COVID. That's what I have seen so far in my clinic.
Okay, super. There's been a lot made about wearing masks. You're supposed to wear masks and wash your hands and social distance. And I'm wondering how the wearing of masks is playing out with some of your patients, particularly asthmatics that might have trouble breathing, that might be, mask averse, for lack of a better term, and how are you seeing that play out in your practice? And number two, how are you guiding your patients? And Dr. Gayam, can you go ahead and answer that?
Yeah, I was very lucky. 70% of our patients are very compliant with instructions of wearing masks, but I do have 30% of patients who needed a little more convincing, educating them the purpose of wearing the mask. We did have a couple of elderly patients who have that moderate asthma, who were complaining that they couldn't breathe, they were uncomfortable. We would advise them to use different types of masks, cloth masks as an option to help them out. And one of our patients had recommended these N95 masks with microfans that are built in, that she said that those are really comfortable to wear. So I don't know how reliable those masks are, but those were an option that we were giving some of our elderly patients to see if they could wear that and feel a little more comfortable. And I know how my parents are, who are in their 80s. Getting them out of the house with the mask, they always complain. And we tried different types of masks with them. And finally, we found masks which don't go over their head, but over the ear loops, which don't kind of come really close to their face, which makes them comfortable. We also experienced with a couple of patients who come in and tell us, including physicians who have to wear these masks all the time, that they're breaking out into a rash with the mask, or they're getting increased sinus infections or feeling more congested. For these patients, we recommended either applying moisturizers on their face before they wear the mask to prevent the rashes, or to wear a shield on top of their N95 mask to see if that will prevent them from being so congested during the day, and using some saline sprays and intranasal steroids to kind of help them out.
Right. Dr. Williams, how about you in your practice with the masks?
Yeah, sure. It's sort of been evolving with this mask. I never thought that if I was on, a round table, people would be asking me about masks. But alas, here we are. What I would say is, in my community in Salisbury, I was talking with another doc about this not too long ago. I'd say about 70 to 80% of patients that we see are wearing masks appropriately in the community. And I think that's important, not just what's going on in my clinic, but also in the community, because if it spreads in the community, then these patients are going to end up in our hospital, overwhelming our hospital system. In my clinic, I have not had resistance 98% of the time. I do not get any resistance from our mandate that you have to wear a mask when you come into the clinic. There are the typical complaints that Dr. Gayam described. I like to remind folks that when I was in medical school, I probably did 4 or 5 months of surgery, and I had to wear the mask, for 6-hour procedures, as did the nurses and the fellows and the residents and the attending surgeons. And they had been doing it for years, decades in some circumstances. And they did not have any sort of ill effect. They have not had ill effect. They're not passing out from hypercarbia or hypoxemia, or some of the other things that people have concern for. Dr. Gayam, I'd be interested to know your experience, but I have had a couple of patients ask me to write letters for them to help to state that it is inappropriate, or I shouldn't say inappropriate, that it is not healthy for them to have to wear a mask. I sort of quell that thought that they're at increased risk for infections. That's just not true. And I've sort of have referred to CDC guidelines. If you're under the age of 2, that could potentially be a reason you're not wearing a mask. If you're someone who's incapacitated and incapable of actually removing the mask from your face, and those are the letters that I write. I've yet to write one that says specifically that a patient can't wear a mask.
I've just been referring to the CDC guidelines, trying to explain to them why they need to wear the mask, but have not given exceptions as of yet.
Interesting. Aubrey, I think we have some questions in the chat. Would you like to read them to the panel?
Sure. One of the questions in the chat box is, could the immunologist comment further on what the heck do they think is going on with the severe COVID-19 I cannot get that word out, I'm sorry. Immunologist with the uncontrolled cytokine storm. Explain this to a primary care physician. Are there cytokine storms in other disease states?
Yeah, I mean, that's that. And when you get an infection, there are inflammatory mediators, cytokines that get activated. It's part of the appropriate immune response. That cytokine storm is why we feel sick. And so, every year, this is one of the things, I used to tell my wife this. One of the things that saddens me, every year, I used to work in the ICU, moonlighting, and every year there'd be a young person, in their 20s or 30s, and they'd come in with the flu and they would die. And the question would always, and they were healthy before. And the question is always, well, why does this healthy person, succumb to the flu? When you're young, particularly when you're young, and you have such a robust immune system, you can generate such a robust response. There is a release of inflammatory cytokines, and these cytokines, they make you feel terrible, but it's how you fight the disease. Unfortunately, there's some ill effects. It can lead to sepsis, and if you have a significant cytokine storm, it can be deleterious. And that immune system gets turned on, it's got to be turned off. Otherwise, you can have, several ill effects. And that is the cytokine storm that you can see in patients who have the flu, viral illness such as the flu or something like COVID. Padma, do you have any other thoughts?
No, Aerik, you covered it well.
There does seem to be a backtracking on steroids with COVID now, that's seemingly in that later phase of the illness where the cytokine storm seems to be kind of the more prevalent or the dominant driver of illness, where dexamethasone or potentially some other steroids may be helpful, which is kind of a complete about face from what we were hearing early on. But again, we're just going to have to keep seeing larger studies, more diverse populations to see how that's going to play out. But that is one of the many situations where there's been almost 100% turnaround, 180-degree turnaround on initial treatment and thoughts of the disease versus what we are now. So I'm curious. I'm hopeful that something like dexamethasone is going to be helpful, proven to be legitimately helpful, probably later in the disease process. But we're just waiting for more studies to show how strong that effect may be if it's there.
Yeah, I mean, if I could piggyback on that, if that's okay. I think that one of the things that should be understood is that we don't know everything. Like, this is fluid, right? And so, what Dr. Gregg was discussing about in regards to steroids in the setting of this viral illness potentially being deleterious in March, that's not where our understanding and our thinking is currently, as more and more data comes out. And the other thing that I would say is that there is some data, that where this concern sort of comes from. There is some data, with viral infections such as MERS, where if you give an inhaled steroid, that actually prolongs viral shedding in the lung. And so, that's sort of where this hesitancy comes from. But as more and more data comes out, as David has said, as more and more data comes out, it should be interesting where this thing goes with steroids.
That's very interesting. David, I want to come back to you and ask you, as a percentage of your patients over time, and let's go back to February and let's fast forward now to July, can you comment about the percentage of your patients that are asthmatics or, have allergies? Has that changed substantially? How has that worked out?
I don't think I personally am seeing anything that's really dramatically different as far as numbers of patients coming in. This is not, I think, and the allergists can speak to this as well, but this is not typically allergy high season. I think the folks that are going to come in are going to come in. I saw a 12-year-old girl last night who just happened to be around a bunch with known asthma, well controlled, not on controller medications, who just happened to be, they were painting in her house and the paint fumes were triggering her symptoms. So you're still going to get those sort of non-seasonal triggers, but there's not been I think, an abnormal spike for this time of year in asthma patients. And I feel like that's probably applicable across the board in larger emergency departments as well. I think this time of year, it's not the high season. We're just getting what we're getting. I think once the fall starts to roll around is when that's when things are going to get dicey, where trying to suss out, is this a standard seasonal asthma exacerbation? Is there a COVID component, a coronavirus component to it? And then how do we treat those patients? Because the standard treatments for asthma, including nebulized medications, are of concern with coronavirus, and we're definitely having to change practice significantly to try to minimize spread. So the patient population this time of year, I'm not seeing any changes, but we know that's coming.
Mm-hmm. You did touch on one thing about meds, and I wanted to ask the panel, and we'll start with Dr. Williams, about medications during COVID for your folks, for your patients. Have you had to adjust their medications, eliminate some? How's that working out?
No, I have not. I have not had to necessarily adjust medicines. I think that it's important, and I tell my patients, it's important during this time period that their asthma is controlled. And like I said prior, inhaled corticosteroids, and in that Northwestern study, being on inhaled steroids, being on inhaled steroid plus long-acting beta agonists, being on systemic steroids, neither of those groups of patients that did not increase their risk for hospitalization to COVID or mortality to COVID. So it's important to know that the medications, that the asthma medications that we're giving them are safe in the setting of COVID. And it's important that they stay on all of those medicines and that their asthma is controlled during this epidemic. So I know I have not had to change the medicines that I've been giving patients.
Gotcha. Aubrey, do you have another question?
Yes, there is a question in the chat box and excuse me if I'm not pronouncing this correctly. Have you seen urticaria associated with COVID-19? If so, any different treatment from usual?
I have not seen any patients in my clinic who tested positive who presented with urticaria, but the studies that are out there, the treatment is exactly the same as you would treat them without the coronavirus. You still use the H1, H2 blockers as well as steroids. The only difference I think would be putting them on a shorter term of steroid dosages, not for a prolonged course.
Thank you. I've got another question kind of in a different direction. I know a lot of folks are not seeing their patients in the office. They're leveraging telemedicine. And I'd like for you guys to take me through your practice and how you're leveraging telemedicine. And is there a certain percentage of your patients that you're pushing to telemedicine because of protocol or some other underlying issue? Dr. Williams, can you start with that?
Yeah, sure. We've certainly leveraged telemedicine. I hadn't used telemedicine until 2020, but it's we've used it. We use the Zoom platform. My group, I'm part of a large group, and we convene sort of a committee that has figured out how to put the program up and running. We've reached out to all of our patients via an email and said, hey, look, if you're interested, and my preference, not only if you're interested, but if you are well, my preference in order to decrease traffic within the clinic is for us to be able to see you via telemedicine. And it's worked out really well. I got an email today that stated that they're actually going to extend the period of time that we're allowed to do telemedicine and still be reimbursed for it. So it's worked out well. It's certainly additive. It decreases the traffic within the clinic, and a lot of the sort of typical allergy, asthma, eczema, hive sorts of things that we see in the clinic. I'm able to sort of care for that over the telephone. What
percentage of your patients do you think you're seeing over telemedicine right now?
Right now, I don't know, 5 to 10%.
Okay.
Earlier on, it was probably 40 to 50%.
Wow, that's a big difference. I want to come to you, Dr. Gayam, for the same question about leveraging telemedicine and maybe pushing a certain percentage of your patients out. Can you address that?
So what we decided to do was we do all telehealth visits only, unless the patient chose to come into the office. We're only seeing patients maybe if they have an asthma flare or conditions that I'm not able to completely treat them over telehealth. We'll have them come face-to-face into the clinic to see them and evaluate. But we have specific days that we're doing allergy shots for our patients where we're limiting the traffic so they come on a set appointment. So there's maximum 2 people coming one at a time into the office, go back and wait in their car, and then come back and get their arms checked. And we're also doing that for the biologic as well, that we keep separate days so that there's no overflow of patients into the clinic. And that's how we've been able to keep everybody happy and keep the practice going.
Yeah. And everybody's safe on your end, right? Keep you and your employees safe.
And a lot of the patients are actually happy not to be driving to the clinic.
Oh, yeah.
And very comfortable with using the telehealth.
Good. Dr. Gregg, I would be interested to hear your take on what you guys are doing, not just in your one location, but WEPA as a group. Are you all able to leverage telemedicine at all?
I'm hearing that it is being leveraged in Raleigh. Where they are using, I mean, it's a combination of, honestly, sometimes they're calling into the patient room over the call system, or, doing follow-ups to limit exposure to patients that are, patients of interest, or patients under investigation, where the physicians or the other providers are calling the patients on their cell phone to kind of recap test results after they've done their initial, exam. I believe there are, and this may not be just limited, I don't think it's limited to, Raleigh, where EDs are using tablets to do telehealth evaluations within reason within the emergency department. But there definitely is a, conscious efforts being made to limit time in the room and exposure to the patient. And they're leveraging everything from the call bell system to just cell phone calls to FaceTiming on patients' own devices, as well as, I think, devices that are being dedicated for use for those purposes in the emergency departments. We're not doing that at my facility right now. We'll see kind of if that becomes, if volumes increase, that may be something that we do start incorporating into the workflow, but we are not there quite yet.
Gotcha. So I want to turn to Dr. Williams and talk a little bit about, during COVID, what's the difference, if there is one, between treating a child or an adolescent in asthma or their allergies versus adults? Has COVID given you some differences there in the treatment of those different folks?
No, I mean, we use the same sorts of medicines to treat adults and kids, asthma and allergies. I haven't had to sort of do anything differently. I don't treat the patients any differently than I would have anyway. So there's really no difference in how I treat adults and how I treat kids. Padma, is that true for you as well?
I don't think for allergies, I don't see much of a difference. But there is a difference in how they present if they were having coronavirus symptoms. I think that would be the only thing. But management-wise, I think when it comes to treatment, there's nothing set in stone for children or for adults. I think it's a matter of trial basis that everybody's going on for treating coronavirus. But for allergy and asthma, I think pretty much the treatments have been the same.
Mm-hmm. Interesting. Dr. Gregg?
We are having to do, I guess, a risk assessment for every patient that comes in with shortness of breath, with a history of asthma or COPD that is wheezing on exam. The NEB treatments that have been a mainstay for as long as I've been practicing, do carry that risk of aerosolizing the virus and potentially, spreading the disease. The alternatives are patients, if they've brought their own inhaler, we can give them a spacer if they didn't bring one, and they can take multiple hits of their own inhaler if they're able to muster the strength to do so. And I actually have had a couple of patients that responded beautifully to that and were just surprised that they had taken 1 or 2 puffs of their inhaler at home to no good effect. And we give them a spacer, we have them take 4 puffs at once, and they feel like $1 million half an hour later. We have been able to incorporate, for patients that are capable of closing their mouth over a mouthpiece rather than having the neb delivered by a mask. We've been able to do that to continue to at least keep nebs as an option in our toolbox. But our facility specifically, we also are kind of going old school for some patients. There are some injectable medications like terbutaline that they have the same overall effect. You just have to do them as subcutaneous injections. It is hard to convince a child to tolerate, 3 rounds of subcutaneous injections versus doing the neb treatment they've always been given. And that is going to create more, I think, concern as, the possibility of asymptomatic COVID or even symptomatic COVID becomes more prevalent potentially in the fall. Can we safely give these kids the nebs that they really do benefit from emergently in our environment? We have a limited number of negative pressure rooms. Ideally, the patient, whatever age, is able to hold their mouth around the mouthpiece, and there's a filter that goes when they breathe out, in and out of that mouthpiece. There's an exhalation filter that we can put a exhalation port that we can put a viral filter on that minimizes but doesn't eliminate risk of spread. It's very much a patient by patient judgment call right now. Can they either bring their own inhaler, use that mouthpiece correctly, muster the inspiratory effort to do a good job with nebs, or are we just going to have to resort to these injectable medications and hope for the best? We have had some good success with that alternative treatment, but it is going to continue to be a struggle when we have limited number of negative pressure rooms. And once we've done that with a patient, we frequently have to take that room out of commission for a thorough cleaning. Like, the room has to sit for half an hour, and then environmental services comes in. And when we start knocking out our 3 to 4 rooms that we can do that in, then that starts affecting patient flow. So it becomes this much greater workflow issue. Not only what meds can we safely deliver the patient the meds that they need, but how is that potentially going to affect the flow of the entire emergency department and spill over into the care of other patients. And there are unfortunately no easy answers. So having as many options as possible is the goal.
Hey, Dr. Gregg, so I try and do as few aerosolized generating procedures as possible. I'm curious as to whether or not y'all have given consideration to doing, neb treatments perhaps outside if possible.
I don't know logistically. That's a great thought. I don't know logistically how we would be able to manage that because we don't have to take we would need to be able to have, I guess, the oxygen tanks. I don't know if we have any compressed air to be able to do nebs on just compressed air, medical air. We are just having to limit it to our small number of negative pressure rooms, no matter what. The outside neb idea, I'll have to think about that to see if there's a way that we can orchestrate it. But I can just immediately name 3 or 4 barriers to that idea from an emergency department standpoint, because you're not able to observe the patient, keep them on monitoring like we typically do. But it's a thought. If we start seeing larger and larger numbers, we're going to have to start thinking outside the box for sure.
It's sort of an outside the box consideration, and there are battery operated nebulized machines, that you could look into. But I know some allergists that are still doing pulmonary function testing, are doing them outside, in order to, because that is an aerosolized generating procedure.
Yeah, I think the monitoring is a big thing. Having patients just kind of walk away. We have a limited, if we get to a point where we really are swamped, where we are setting up tents like we're being set up in some of the area emergency departments, that becomes maybe more of a possibility. from an ED standpoint, given this, with the variable stability of the patient, having, treating them outside, physically outside, there probably would be a small select few that might be okay, but that we would still have the logistical challenges of how we're going to actually deliver it.
Sure.
Aubrey, I think you might have one more question.
I do. In the chat box, someone asked if you saw a COVID-19 patient with wheezing, let's say no previous asthma, would you treat them with inhaled steroids?
I would, as long as they don't have fever or any other explanation to their cause of wheezing, because they could have cardiac wheezing, which inhaled corticosteroids would not be a good option. But if they didn't have fever and if they didn't, because I think that what differentiates between the coronavirus and the asthmatics, the fever and the wheeze.
So to be clear, that the question was whether or not if a COVID patient had wheezing, would I treat them with inhaled steroids?
Yes, sir.
If we know that they have COVID?
Yeah.
Just as a treatment. I mean, I haven't, maybe I'm wrong, but I haven't seen that as sort of a therapeutic option. For COVID patients wheezing, I haven't seen inhaled steroids as a therapeutic option. I don't know if anyone else has seen that. I certainly could be wrong. I don't know all of the data.
No, I think there is. I'm seeing a lot of folks. I guess I am part of a 20,000+ strong Facebook group of emergency physicians, mostly based in the U.S. Lots of things being talked about with COVID, and I think a lot of them are sending folks home with an albuterol inhaler for the beta agonist effect, but I don't think they're routinely doing the inhaled steroids to go with it. So many of our patients would never be able to afford a inhaled steroid MDI anyway, but the beta agonist inhalers for sure, not so much the steroids.
Okay. Dr. Williams, you are also a professor at Campbell School of Medicine. And I know we talked a little bit before the call, and I wanted to get your take on what changes you've made to teaching some of your students about your profession and how they should react during COVID.
So that's a good question. Well, first of all, the students, they're just getting back to rotations, over the past month. They were out, so if you have a newly minted intern, they didn't study any inpatient medicine for the last 3 to 4 months of medical school. And, now they're on the wards, taking care of patients. I think, and then I'll answer your question directly in just a second, but, I remember when I was in medical school, I was one of my internal medicine attendings practiced out in San Francisco before she came to Ohio. And she practiced, and she was training. I think she was a chief resident during the sort of peak of the HIV epidemic in the United States. And so that was sort of like a sentinel moment for her and for her colleagues. And I think that, and to a bit differently, but I think that, our med students now, this is sort of their sentinel moment. This is, they've been taught certain things about immunology. And now we're experiencing something real time where we don't know all of the answers. And so we're sort of piecing this thing together and using science to sort of, guide decision making. So it's a really cool time. This is what I tell them. This is a really cool time to be studying medicine. It's a fascinating time because of all of the opportunity for discovery. And you're going to see this discovery sort of play out over the next several months. RNA vaccines, DNA vaccines, the creation of biologic medications that target specific areas on the virus in order to inhibit that virus. What a fascinating time to be in medicine. So specifically to answer your question, I have them do the same sorts of precautions that, we do as that my staff does in the clinic. and emphasize as to why it's important. I have tailored my immunology sort of discussions and talks to talk more about cytokine storm, that sort of thing, and sort of the immune system that recognizes and eliminates viruses. So it's a fascinating time for the med students to be learning medicine. I haven't changed my practice with them all that much. I just make sure that they're safe, understand why we're doing some of the things that we're doing. So.
That's great. Thank you. Okay, we're getting close to the top of the hour, but I want to take one more time to go around the horn with you guys. And just, could you tell me, and we'll start with Dr. Gayam, what lessons have you learned during the last, 4, 5, 6 months that you would impart to these folks?
To be open-minded, of learning to practice in different ways than what you're used to. And I think we really learned within the last 2-3 months how to adapt to telehealth. And we're looking forward to continuing with it in our practice.
Super. Dr. Gregg?
I think Dr. Gayam stole my initial thought, which I was just going to state as be flexible, be vigilant, be prepared to reverse course at a moment's notice when the latest evidence shows potentially something different than what we have been practicing so far, and practice, self-health as much as humanly possible, because this is going to be a marathon. Dr. Williams talked about a few months. I'm afraid that this may be something that is continuing to dramatically affect our practice well into the next year, if not longer. There's no guarantee that this moonshot effort at a effective and safe vaccine is going to give us the result that we want. So that's it. Be flexible, be vigilant, and be prepared to change at a moment's notice what we do.
Super. And finally, Dr. Williams.
Yeah, I have to answer last, and you guys took all of my
good stuff.
talking points. But if I could echo one that Dr. Gregg made, and that's preparedness. One of the things that has struck me is just sort of how unprepared we are. And I mean nationally, I mean locally, I mean in my clinic. I should always have, some N95 masks in my clinic. I should always have some, protocol in place just in case one of these things, happens where there's a pandemic with a virus that affects the respiratory system. Make sure that I'm prepared and how to socially distance within my clinic, et cetera. So preparedness is what it is that is sort of what I've taken away from this.
Super. Well, Tina, I'm going to give it back to you, but I want to give a shout out to the panelists today for providing some great answers. You guys have been very conversational. Thank you so much for your time. Tina, back to you.
Thank you.
Thank you so much. And I also want to thank our guests today, Dr. Gayam, Dr. Williams, Dr. Gregg. Thank you so much for taking the time and being the guest for today, this week's Power Hour. And also thank you to all of you who chimed in today and who joined us for this conversation as well. This wraps up this week's session. We want to remind you that we're taking a bi-weekly session now during the summer. So our next session is going to be in 2 weeks. So please check out our website and see what announcement comes out through the morning rounds in terms of the topic and the guests for that. But without any further ado, I want to remind you all again that these forums are a platform to really keep building this community that we have, and we are here to help and assist in any way we can, to thank you also for all the work that you do out there for us. So again, thank you so much to our guests. We really appreciate you, and we thank you to the audience, and have a nice weekend.
Thank you.
Thanks, you too.
Thank you.
Thanks, everybody.
Thank you.